Thank you, Laurie. These are my disclosures. So my task today will be to try to tell you what can be expected when improving the immune components in the treatment of diffuse large B-cell lymphoma, namely using monoclonal antibodies, novel antibodies, drugs that are on the shelf contrary to the CAR T cells. And the good news is we have a huge bunch of new monoclonal antibodies, not only targeting the B tumoral cells, targeting the CD30, the CD79B, the CD19, but also other cells that are important in the microenvironment, such as the T cells, and there you can target the immune checkpoints, CD137, the PD1, PD-L1 immunostat, or the TIM3, or even more simply, the CD3, to take advantage of bispecifics antibody. But you can also target another immune checkpoints on macrophages, namely the don't eat me signal CD47. What I'll try to show you is a selection of the most significant ones in terms of learnings in each of those families. And let's start with the PD1. I think the results with the PD1, it's pretty fair to say that the activity as a single agent is clearly minimal when you see on the right-hand side the overall response rate was 10% in patients that failed stem cell transplantation, even if some of the responders, the few responders, may have a long response duration. Unless there is a very significant underlying biology, such as the amplification of the PD-L1 in the 9p21 locus, for example, in 55% of PMBL or other subtypes of diffuse large B-cell lymphoma. The toxicity was not an issue with the PD-L1. You see that immune-mediated AEs grade 3 and 4 was less than 1%. This very low activity as a single agent doesn't mean that it might not be efficient in combination, especially with chemotherapy or other drugs, and this is probably the future for this compound. Blocking the don't eat me signal CD47 with the humanized 5F9 antibody takes the foot off the brakes and leads to increased phagocytosis. And this process is substantially increased by the addition of rituximab, as was nicely shown by Ranjana Advani in her New England paper. You see that, of course, it's a restricted number of patients and probably highly selected. Nevertheless, in those patients that had received a median line of 4 prior therapy, and of whom 60% were refractory to their prior regimen, the overall response rate in the diffuse large B-cell was 40%, and the most promising being a CR rate of 33% and a median duration of response that is not reached. So we have to see how the data mature, but this newcomers is really an intriguing one. In terms of targeting the B cells, one of the new players is the Fc-engineered CD79B MOR208, tafasitamab. Here I show you the results of the phase 2 of this antibody as a single agent. You see that the overall response rate in diffuse large B-cell lymphoma was 26% with 6% CR in patients that had a median numbers of 2 prior therapy and of whom 69% were rituximab refractory. You also see that 74% of those patients had relapsed within 12 months of their most recent treatment, so a difficult to treat patient population. Nevertheless, the 26% is not enough and is calling for further combination. There is a phase 3 trial looking at the combination with bendamustine, but I think the most intriguing one and the most interesting currently is the one in combination with lenalidomide as a kind of follower of the R-square regimen. Patient will receive in the L-MIND study lenalidomide at a starting dose of 25 milligram, 3 weeks on, 1 week off, during 1 year, in combination with weekly dose of the antibody for cycle 1 and 3, and then every 2 weeks for cycle 4 to 12, and then a maintenance. Here, it's extremely important to notice that the patients that were primary refractory were excluded, and the patients could not receive more than 3 lines of prior therapy. And please keep that in mind when you will compare that with the polatuzumab data. But the median prior therapy was number was 2 lines in this group of patients. The safety was okay, and the overall response rate is promising in this group of patients, 60% with 40% CR. In the press release, and there will be a presentation by Gilles Salles at this meeting, the median PFS is now 12 months, but the median duration of response is close to 2 years. Another interesting component is the bispecifics antibody that trigger the formation of an immune synapse, thus releasing perforin and granzyme and leading to T-cell kill, to B-cell kill. Here, you notice that there are many different constructs of bispecifics going to monoclonal antibody conjugates through cross-mAbs, and other who are lacking the Fc domain, like the BiTE or the DARTs. One of the first that was tested, the BiTE, was the blinatumomab. And in this trial, in aggressive histologies, there was a moderate efficacy in the phase 2 study with an overall response rate of 37%. And this treatment was not easy because it has to be given at the continuous infusion, and the toxicity was not nothing. You see that there was 24% of grade 4 and 17% of patients that had AE leading to treatment discontinuation. So probably a concept that is interesting, but PK that is not optimal. I selected 2 bispecific antibodies that are currently developed by Roche, not only because they are developed by Roche, but because the results that have been shown in the recent Congress seems to be the most appealing. The first one is mosunetuzumab, which is given with a step-up, as you see here in Group B, up to doses of 60 milligram. It's a 1-to-1, one side for the CD3 binding, one side for the CD20 binding. The safety was okay, with not too much CNS toxicity and an expected number of CRS. And the best overall response rate at the dose that have currently been tested was in Group B for diffuse large B-cell lymphoma, 34%, with the CR rate of 19%. Even more interesting, at least to me, is the second compound, the TCB, with a novel 2-to-1 form of T-cell engaging. You see that there are 2 CD20 binding sites and 1 CD3 binding site. And here, the way to give the antibody is a little bit different because there is a pre-treatment by GA101 to mitigate the CRS. And then there was a very quick dose escalation up to 25 milligram. Here, what is shown is the results that were presented at ASH. And really interesting is the overall response rate at the highest dose, 10 to 16 milligram. It was 55% and a 27 CR rate. So a very good signal with managing toxicity. Both antibodies are still being developed, and there is some fine-tuning to find the best way of giving this antibody as a single agent for further combination. The antibody-drug conjugates associate the highly desirable pharmacokinetic and targetability of monoclonal antibody with the cytotoxicity of small drugs. It's not an easy business. There has been many drugs that have been developed in this particular setting, and what is key is the chemistry of the linker, beside the antigen that is targeted, and also the payload. And most of the current antibodies that have been developed can be split into payloads that are anti-mitotic and payloads that are DNA damaging. I show you here example. The DNA damaging, you have the calichyamicin and the doxorubicin, and all the others are anti-mitotic. In fact, most of these drugs, even those that went to the phase 3, like inotuzumab, the CD22 with the calichyamicin, have been stopped in diffuse large B-cell lymphoma because the results were insufficient, or even when the results were insufficient or good in the starting in the phase 1b, you had problems in combination with chemotherapy, as was found, for example, with denituzumab mafodotin targeting the CD19 from CL2 genetics. Here is an example of one of these antibody that was tested and ultimately failed. This is a phase 2 of the coltuximab riftansine. You see that the overall response rate was not bad altogether. It was 44%. But if you focus on those patients that are really in medical need, those that were refractory to the last regimen, or those that were primary refractory, you don't reach the bar of the 30%. And the median PFS was not promising. In this context, the two ADCs that stands out are those with the similar chemistry, with a linker that is valine citrulline, so a cleavable peptide linker that is enzymatically cleaved in the lysosome, and a payload that is an anti-mitotic MMAE. You are all familiar with the CD30, the brentuximab vedotin that has been now approved in Hodgkin lymphoma and also in some of the T-cell lymphoma, the ALK positive. And the second one is the polatuzumab vedotin. I just want to briefly show you the results of brentuximab vedotin in diffuse large B-cell lymphoma. It was okay in terms of overall response rate, 45%, with a 17% CR rate, but we will see later that one can expect something better with a different ADC. The safety profile was okay. And the next, of course, is the polatuzumab vedotin. I told you it was a cleavable linker. And Laurie will show you why we think it is currently the best ADC developed in diffuse large B-cell lymphoma. With that, I will conclude. In summary, I think we can now say that we have alternative targets beyond CD20, and all these targets can be exploited by cytotoxic agents to create immune synapse and to bring further benefits to the patient. And the key will be to find now the best combination therapy to try to mitigate the issue of resistance as well as increasing the selectivity of those treatments. Thank you for attention.